Hi, we are still busy with the hypertensive conditions, and I am still Anna Nolte. And today we're going to do lesson 3, which is the pre-eclampsia part, and we're specifically going to talk here about the general aspects of pre-eclampsia, assessment, etc., and then specifically the management of mild or moderate pre-eclampsia. Now, the definition of mild to moderate preeclampsia is if we have a diastolic blood pressure of 90 to 109 and a systolic pressure of 140 over 159. So a blood pressure of anything from 140 over 90 to 159 over 109. We've said that 160 over 110 is a serious preeclampsia. That together with 1 plus protein. And usually with mild to moderate preeclampsia, there's no organ dysfunction. Remember, I've said when we did the pathophysiology, the worse the condition, the worse the organs are being affected. So if the condition is not bad, the vasospasm is not bad enough to cause all that bad effects and bad pathology on the different organs. So in this case, we just have mild to moderate preeclampsia and we have no organ dysfunction. Now, the assessment of a patient with preeclampsia, and this is a general principles, whether the patient is now having serious preeclampsia or whether she has moderate preeclampsia, the assessment is exactly the same. And if you think and revise in your heads everything that we have said about the pathophysiology, what goes wrong in the body, it makes the things that we are assessing the patient for make so much more sense. So first of all, we will take a full history of the patient to determine which women are at risk. I have given you a list of women that might be at risk. A very young woman or a woman older than 35, patients with previous preeclampsia, history of previous preeclampsia, etc. Then obviously we need to determine the blood pressure. Now what I'm saying here in brackets is that the interval depends on how serious the condition is. Obviously, the more serious the condition, the more often we will take blood pressure, and the less serious the condition, the bigger the interval will be. So one will, if you, for example, admit the patient now with hypertension, you will start with if the blood pressure is, if the condition is mild to moderate, one will start with 1 to 2 hourly blood pressure measurements, and if it stabilizes, one can even go as far as 4 hourly. But when it becomes more seriously, obviously, we will do it more often, like in half hourly and even every 15 minutes. We need to determine whether there's protein in the urine and how much protein in the urine there is, which will also indicate, give us an indication of how serious the condition is. Edema and weight gain. Now, weight gain as such is not so important to us, but weight gain is an indicator for us of how much edema the patient is having and to what extent the edema is increasing. So we do, especially in more severe cases, we do measure the weight regularly to see in what way the edema or how much the edema has been increased. Then the different blood tests. And I think here you can see very clearly what we have said about the different organs. We usually do a full blood count in order to determine specifically what the relationship is of the different blood cells to the volume part, and also specifically to see in what way the coagulation factors in the blood has already been affected. We also do a platelet count and clotting time to see, as I'm saying, in what way has it already been affected. Is there a decrease in the platelet count, which is very important for us? Is there a rise in the serum creatinine, which tells us that the glomerulus of the kidneys already been affected, and that causes less filtration of the creatinine into the urine. So that makes that the serum creatinine is increased or raised. and the same with the uric acid levels. And then we do liver function tests to determine in what way is the liver already being affected by measuring the liver function tests, and also by determining whether there's already elevated liver enzymes or not. Further, with regarding the assessment, we've said it's very important to determine the fetal condition, because we have seen to what extent the placenta has been affected or affected by this hypertension preeclampsia. So obviously sonars will be done regularly to determine whether there's already growth retardation. A CTG will give us an indication of how well it's going with the fetus. And then very important is fetal movements and education to the mother about fetal movements, so that specifically when she goes home that she's able to monitor her own fetal movements and determine whether the fetus is moving enough or not. Fluid balance in preeclampsia is always very important for us, because as we've said, there's this increased interstitial leakage which causes that there's edema and edema, and then also specifically pulmonary edema. So to manage the fluid balance of the patient very carefully during hypertension is absolutely essential to see and prevent specifically pulmonary edema. And that's why it's so important to determine the plasma volume and to see in what way is there already hemoconcentration, in what way is the plasma volume already decreased to a large extent. Abdominal examination, the reason why tenderness and hard is being put here is that, as I've said, there is quite a association between preeclampsia and abruptio placenta. So if the abdomen is tender and hard, there might be bleeding in the uterus, which we will come to when we do the obstetric hemorrhages in the next course. So this is very important then also for us. And then very, very, very important are the symptoms of imminent eclampsia, saying to us, these symptoms are saying to us that it's really progressively going worse in the different organs that's been affected by the preeclampsia. And those are headaches, epigastric pain, and visual disturbances, which we have often said now, and which you should clearly remember. And also, together with teaching the patient on the fetal movements, these are so important to give education onto the woman that she can immediately report if she experiences any of these symptoms. Now, there's not really a way that preeclampsia can be prevented, and that's unfortunately one of the things that I also say in all the many years that we have with preeclampsia and all the research that has been done, we still struggle to get a way in which to prevent those abnormal placental formation. Research has been shown that in some cases, and specifically high-risk cases, if we give the mother anticoagulants or antiplatelet agents early in pregnancy, it might decrease the incidence of preeclampsia. But there's only a 10% decrease in the possibility. And aspirin is usually the medication that's been used most often here. So we can give mothers aspirin. It's only cause a 10% less chance of developing preeclampsia. But I think every percentage that less of women that does not develop get preeclampsia already helps. Then there's also a lot of research that has been done on calcium supplementation. And it has been found that in women where they have a deficiency in their calcium, in their normal diet, it might help them to prevent preeclampsia if they receive calcium supplements during pregnancy. So that's why all women in the public sector receive calcium supplements during pregnancy, because usually very often women in the public sector are the women that's undernourished and will have a calcium deficiency. So in order to prevent that, they all get calcium supplements. Now, there's no way that diet manipulation will help with the prevention of preeclampsia. It's, for example, lots of research, and we will come back to that again, lots of research has been done on salt restriction. And as you can remember from your pathophysiology that we've done in the previous lesson, there was not one single aspect that we have mentioned that this has been caused because of a lack of natrium or any of those, so, or too much of natrium. So it does not help at all to limit the salt intake of women and in order to prevent or even to treat preeclampsia. There's also a lot of debate on the protein that the mothers lose in their urine, whether it should be replaced with more protein, and we will come to that again. But again, there's no real evidence that that makes a difference in the development of preeclampsia. Then whether women should have exercise normally or not, doing more exercises or doing more physical walking around or whatever, whether that has an influence on better blood supply, etc. Again, there's no evidence that exercise plays a role in preventing or treatment of preeclampsia. Now, the principles of care, what's most important when we care for a patient with preeclampsia? Again, if you think of all the pathophysiological changes that we've done and talked about, I think it's obvious what we need to try and control and what we need to properly assess. Now, usually, remember we're talking now about the patient with mild preeclampsia. It has been, and you will hear I talk about evidence a lot and research a lot. It has been shown that it's not really very effective, might be the wrong word, to hospitalize a patient for a very long period, because these patients become, and we will see also because of the effect of some of the medication that they receive, become if they have to stay in a hospital and they're not really sick, become depressed quite easily. So there's also evidence that the patient can be treated on an outpatient care basis with good education on when to come, and obviously the patient must be reliable, that you know that you will come if all these signs of imminent eclampsia is present, or if any of the signs of fetal compromise is present, the woman can be treated on an outpatient care. So usually the patient's been admitted or might be admitted and the blood pressure is stabilized. All the tests are being done, all the blood tests are being done, sonars are being done, and the patient can go home on an outpatient basis and being treated like that. And obviously she will be seen more often during the antenatal period there. We have talked about all the assessments that one's supposed to do on these patients on the previous slides. And then very important, obviously, is to control the blood pressure, to try and control the vasospasm, because we have seen that the vasospasm is the reason for all the effects on all the different organs. So the worse the vasospasm, obviously, the worse the effect of it on the body. So if the better we can control the blood pressure, the better we can control the whole condition. But that is not always possible. In some, and again, that's what makes it so difficult in this condition, is in some cases it's easy to control the patient's blood pressure and they end up in a good condition, etc. And then in other cases it just gets out of total control and there's no way that one can control it. Then obviously also we will come to the different medication to control the side effects of the medication, to evaluate the condition of the fetus as best as possible. And then the timing of the delivery is very important. And I've put there a query because, as I've said previously, the only cure for preeclampsia is to deliver the placenta, because all these problems are starting in the placenta, because there's hypoxia in the placenta, and because of that we get these factors that influence the epithelial system. Now, this will depend on how controlled the condition is. The better, obviously, the controlled the condition is, the better the prognosis will be, and the longer the pregnancy can last. In a condition like this, always the maternal condition is priority. So the fetus, the pregnancy will rather be terminated in order to save the mother's life and in order to cause as least as possible complications to the mother, instead of trying to save the fetal life. So the timing of the delivery will totally depend on the condition of the mother, on the condition of the different organs, etc. Now, the basic principles when we care for this patient, what is so important in the caring of this patient? Now, as we've said now several times, the main aim is to decrease the blood pressure. And all the bullet points here under that is aimed at decreasing the blood pressure. So, rest, and the reason I've put evidence there is there's again no evidence that the patient should be on complete absolute bed rest. There is evidence that if the patient rests more often, 4 to 6 hours daily, it might keep the blood pressure kind of under control. It will not solve the problem, it will not decrease the blood pressure, but at least it keeps the blood pressure under control. So it's not necessary that the mother stay in bed all the time, but it is definitely advised, and especially when she goes home, to advise her to rest more often. And specifically also very important, if the mother still work during pregnancy, that she definitely take the time off to rest more often. And whether she will be allowed to work or not will obviously depend on the seriousness of her condition. Then, as I've said, there's evidence, lots of evidence and research that there's no effect of a low salt diet on improving the condition of preeclampsia. So it's not necessary to give the mother a low salt diet. Yes, we can give her some education on not using extra salt that we teach all patients, whether they are hypertensive or not, but it's not necessary to give them a low salt diet. The mother should get a normal, very well balanced diet. It's also not necessary to increase the proteins in the diet as long as she eats a normal, well balanced diet. Now, weight gain, as I've said, is not so important in the sense of weight gain, but in the sense of determining whether the edema is increasing or not, which is also an indicator for us that the condition is getting worse or not. So the weight gain of the mother, and again, education around that is very important. Then antihypertensive treatment in the sense of, and these 3 drugs that I've mentioned, that I've put here under the 3 bullets, are the most important ones, and we will talk about each one of them separately. Methyldopa, which we have talked about earlier, nifedipine, and magnesium sulfate. And then depending on whether the pregnancy is going to be terminated, if the mother is less than 34 weeks pregnant, it's also good to give her steroids in order to for lung maturation if the pregnancy is going to be terminated. Now, when we talk about antihypertensive drugs, there are some very important aspects to keep into consideration, and this is the very important one. Is yes, we do want to reduce blood pressure, but we want to reduce the blood pressure very gradually, because if we reduce it too fast, we are going to cause the whole body is now used to work against the vasospasm and to work against the high blood pressure. So the moment that we immediately cause a drastic reduction in the blood pressure, we are going to cause also organ cause problems to the different organs, and specifically to the kidneys, and then definitely also to the placenta, because we decrease the blood pressure in the placenta to such an extent that we have an influence on the oxygen transport to the fetus. So we usually say that we want to keep our systolic pressure in the area of 140 to 155 millimeters mercury, and we don't want our diastolic pressure to go much lower than 90 millimeters mercury. So we also want to keep that between 90 and 100 millimeters mercury. And that's again why I've in the very first lesson taught you how to take the blood pressure. That's why it's so important to take accurate blood pressures during preeclampsia. Now, if we look at each one of these medications separately, if we look at methyldopa, and the pharmacological name that I have here is Aldomet, because that's the most well-known one. As I've said previously, there are also other pharmacological names for methyldopa. Now, what it does is it works on the hypothalamus and the medulla. So it works centrally on the central nervous system, and that makes the blood pressure to decrease. So that's why we're saying here it acts centrally to produce a decrease in vascular resistance, and decrease obviously therefore the vasospasm, and decrease therefore the blood pressure. Very important, it's a long-acting drug. It takes about 24 to 48 hours to act. So it's not going to decrease the blood pressure immediately. So the reason why we give it as an emergency, and you will see we do give it as an emergency, is not to decrease the blood pressure immediately, but to decrease the blood pressure over a longer period. Now, there are many other smaller side effects. The most important side effect for me here is that it does cause a little bit of sedation, and because of that, the mother, especially if they get higher dosages of Aldomet, becomes sedated and sleepy. And if that goes on over a long period, it might also cause them to become a little depressed. So this is also very important to teach mothers when we give them education about the effects of all the hypertension and all the signs and symptoms. It's also important to teach them about the sedation, the sedative effect, and the possible depression because of that. Now, it's a fairly safe drug. We can give up to 500 milligrams 3 times a day, 250 or once a day, daily, depending on the seriousness of the maternal condition. Our next drug is nifedipine or Adalat. It's a calcium channel blocker, and by being a calcium channel blocker, it causes vasodilatation. And that's what we need, because we want to decrease the vasospasm and the effect of vasospasm. What is very important to remember is that it's also tocolytic. It means that it decreases contractions. So, might play an important role during labor if we give nifedipine for hypertension during labor. So just take that into consideration. Now, what is important with nifedipine is that it has a quick onset. In comparison with Aldomet that we've said just previously, takes 24 to 48 hours to work. This works almost instantaneously. It works very quickly. So the two in combination actually works very well, because this starts quickly and then the Aldomet keeps on the good work over a longer period. Now, because of this vasodilatation that nifedipine causes, it also causes obviously headaches and this flushed feeling. It also causes the increase in the pulse rate to a certain extent. So it's also not a very pleasant drug for the mothers to receive, and also again needs a lot of education on these side effects. Also again a very safe drug. You usually start with 10 milligrams, but it can be repeated in 10 to 20 minutes, and it can be increased to up to 120 milligrams over this period. So as I'm saying, quite a safe drug. Our next drug is magnesium sulfate, and that we usually use in more serious cases of preeclampsia. And the action here is to trigger specifically cerebral vasodilatation. And this reduces the ischemia. Remember, we've said that's the main problem in the brain, and that causes the vasospasm in the brain causes the ischemia, and that causes eclampsia. So if we can get cerebral vasodilatation to prevent all these in the brain, it's a winner. And that is basically what the main aim with magnesium sulfate is, to prevent eclamptic events. It's also a calcium channel blocker with vasodilatation, like we've said previously with nifedipine. It also depresses the central nervous system, so that also makes the mother a little bit sedated and depressed. And then also, very important, it blocks peripheral neuromuscular transmission. So the transmission of messages as it goes along the nerves, it blocks it to a certain extent. And then it also, the most important effect, it has an anticonvulsant effect, and therefore prevent convulsions or treat convulsions if the patient is already having convulsions. The side effect, because it depresses the central nervous system, it also depresses the respiratory center, and that is very important. So there are two things here that's important, because it depresses the central nervous system, and obviously because it depresses the respiratory system, we should be very careful that we not overdose magnesium sulfate. In comparison with the two previous drugs, which I have said is very safe, it's a little bit of the opposite with magnesium sulfate. So we always need to take the side effects very seriously into consideration. The fact that it causes respiratory depression and in general depression, we have to make sure that we don't overdose. It also, because of this central nervous system depression, it also causes a reduced fetal heart rate variability, like any medication that causes central nervous system depression, like impethidine, for example. So we need also to check that. So it's very important that before we give any further magnesium sulfate dosages, before we give the next dosage, is to always determine the tendon reflex, and also to count the respiratory rate of the mother, to make 100% sure that that we are not overdosing the patient with magnesium sulfate. So we test it by testing a knee jerk, by doing the knee reflex, and make sure that there is a knee reflex. If it's absent, we know that we are already giving too much magnesium sulfate. We have to measure the urinary output. If it's less than 100 moles in the last 4 hours, it might also be because of the effect of the magnesium sulfate. But also remember that the more serious the preeclampsia, also a late sign is oliguria. So this might be because of the magnesium sulfate, but it might also be because of the seriousness of the condition. And then we check the respiratory rate. If it's less than 16 breaths per minute, we know that there's quite a lot of depression of the respiratory rate, and we should not give more magnesium sulfate. The calcium gluconate is the drug that we use to reverse the effect of magnesium sulfate. So if we have overdosed the patient with magnesium, we give a calcium gluconate 1 grams IV over 10 minutes to reverse the effect of magnesium sulfate. Now, I've said we will talk briefly about care during labor, like we've said previously with the gestational hypertension. If the patient does get an epidural, it's very important to very well control the blood pressure, to really check. Now, remember, here are two very important things: the blood pressure as well as the hypovolemia. So we must check the output and input of the patient very carefully, because if we overload the patient with too much fluid in order to control the blood pressure, we might cause pulmonary edema on the other hand. So very good control of blood pressure and fluid here is very important. Then usually the second stage will be assisted to make it as short as possible so that the patient does not push too long during the second stage of labor. We have talked about the fact that symptometrin is contraindicated because it causes a tonic contraction, which might worsen the condition. Rather, syntocinon should be used. And then, very important, these patients, because they already have hypovolemia, cannot afford to have a hemorrhage as well. So, very careful observations during the postnatal period for the possibility of a postnatal hemorrhage or a postpartum hemorrhage. Now, the postnatal period is for two reasons very important, and as we've said just now, it's for postpartum hemorrhage, but also for, I have previously said that very often signs get quickly worsen quickly during the postnatal period. So that's why good postnatal observations are extremely, extremely important. Again, brings us to the end of this lesson. There are some so important things and aspects in this lesson. I hope that you've learned something and complete your quiz so that you can continue to the next one.